بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. اليوم إن شاء الله نتكلم على interesting topic from interesting case in the last 2 weeks. This is a topic by name CMV in kidney transplant. CMV is the most common differential diagnosis for any patient, especially with GIT symptoms or signs emerge in the patient with abdominal pain, or especially with diarrhea, or whatever. You should think in CMV, especially patient with kidney transplant. اليوم إن شاء الله أتمنى الجميع يستفيد من هذه المحاضرة، وإن شاء الله تكون محاضرة قيمة، وإن شاء الله الجميع يخرج باستفادة اليوم، وإن شاء الله نحاول نبسط المعلومة بإذن الله. توكلنا على الله. بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. أولا نبدأ بالصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. The first, you can't improve what you don't understand. You should understand the disease or the complaint of your patient and start your management to end by final best approach for best outcome for your patient. You should understand what you are treating. Our objective today is background. We'll just give a hint of background of CMV virus, to provide some information about CMV virus and the route of transmission, risk factor for CMV viremia and nephropathy, and the clinical consequence of CMV infection, and to highlight the differential diagnosis and the screening guidelines, to highlight the histological similarity between CMV and rejection. What is the histological similarity between both diagnosis and detection, between differentiation between CMV and rejection in kidney transplant, to discuss the management of different treatment options for CMV. CMV almost always on the transplant patient differential diagnosis. You should think in any patient came post-transplant with any symptoms like fever, like abdominal pains, weight loss, night sweating, and elevated liver function test, pancytopenia, and all come to all this in details. Just put CMV viremia post-kidney transplant differential diagnosis for any symptoms post-kidney transplant. We'll start as usual by interesting cases. I thought already. A 50 years old female patient presented 3 days history of malaise and fatigue for 2 months. Malaise, just unspecific symptoms, just malaise, fatigue, and unable to do her task at home after receiving deceased donor transplant with ETG, T-cell depleting induction therapy. Patient discharge medication after transplant including tacrolimus, Advagraph, mycophenolate mofetil MMF or myfortic, prednisone, and valganciclovir for CMV prophylaxis. Because this patient already ETG and received deceased donor, all this should be covered by CMV prophylaxis. Of note, the patient received seropositive. That's the second problem now. The patient received seropositive donor positive CMV IgG positive organ and was seronegative, and the recipient is negative for CMV IgG. So now there's another risk of maybe will prolong the course now for 6 months now. ETG only, this maybe 3 months, but ETG with donor with CMV viremia mismatch, donor is positive and the recipient is negative, will give CMV prophylaxis valganciclovir for 9 months. On exams, the patient physical exam and basic lab testing were unremarkable. Kidney function remained at baseline with creatinine 2.2 milligram per deciliter. Despite valganciclovir prophylaxis, she was found to have CMV viral load of almost 500,000. 5 logs already, international unit per ml. Replication of CMV and CMV DNA virus, and this member of herpes viridae family and kidney transplant recipient can be symptomatic or asymptomatic or symptomatic. Asymptomatic is subclinical CMV infection, like just you will find high CMV PCR. Symptomatic and manifest as CMV disease. CMV disease is further classified into tissue invasive CMV disease with organ involvement, most commonly cause enteritis or colitis. Most common site of you found CMV viremia, either enteritis or colitis, but also hepatitis, retinitis, meningitis, pneumonitis, allograft nephritis. You should think for this CMV symptomatic invasive tissue invasive disease like enteritis, colitis, hepatitis is the most common presentation for CMV viremia post-transplant, either enteritis or colitis, hepatitis, retinitis, meningitis, pneumonitis also, and allograft nephritis by AKI or rising creatinine or graft dysfunction. CMV disease without organ involvement typically present with fever, malaise, myalgia, leukopenia, and thrombocytopenia. Leukopenia, thrombocytopenia, and fever, malaise, myalgia, leukopenia, thrombocytopenia, similar to our patient. After 1 week of intravenous ganciclovir therapy, the patient's symptoms begin to improve. So the serum CMV viral load increased over 1 million from 500. But 1 week, symptoms improve after IV ganciclovir. CMV and viral resistance to the first-line therapy should be suspected if CMV viral load fails to decrease or rises or persists beyond 2 weeks of adequate therapy. This means, what is the definition of CMV antiviral resistance? Should be suspected if CMV viral load failed to decrease or increased or persistence beyond 2 weeks of adequate therapy. The most common antiviral resistance encountered is that to ganciclovir, so resistance can be seen to all agents. The most important risk factor for resistance is CMV mismatch. CMV mismatch is the most common risk factor of resistance, like donor positive and the recipient is negative. Other known risk factors include chronic immunosuppression and suboptimal of ganciclovir. CMV drug resistance testing most commonly check for mutation in two genes. Any patient with CMV drug resistance not respond to IV ganciclovir, you should think to check this mutation in two genes, UL97 kinase and UL54 DNA polymerase. UL97 kinase, UL97 kinase, and UL54 DNA polymerase. UL97 kinase and UL54 DNA polymerase. This mutation encodes for viral kinase that mediates triphosphorylation of ganciclovir into the active ganciclovir triphosphate and the CMV DNA polymerase respectively. This mutation encodes for viral kinase that mediate triphosphorylation of ganciclovir into active ganciclovir triphosphate and the CMV DNA polymerase respectively. This polymerase is a target cell for all three anti-CMV. This polymerase target for all three anti-CMV drugs, the ganciclovir, foscarnet, and the cidofovir. Now this polymerase is a target for all the three anti-CMV drugs like ganciclovir and foscarnet and the cidofovir. In our patient CMV resistant testing field to detect a mutation, we already did mutation for these two genes, UL97 kinase and UL54 DNA polymerase, already negative in our patient after 2 weeks. After 2 weeks of treatment with ganciclovir, the CMV viral load decreased, and the patient was discharged with 900 milligram oral ganciclovir twice a daily. Treatment should continue for at least 2 weeks or until the viral load is undetectable, whichever is longer. Guidelines suggest discontinue therapy after one negative CMV PCR using the highly sensitive quantitative nucleic acid amplification assays NAT CMV PCR or using NAT. If negative, we can discontinue the medication. CMV viremia and disease continue to carry high risk of morbidity and mortality and can significantly impact the graft function. The clinical presentation can be variable. Recognition and appropriate treatment are crucial to optimize transplant or outcomes. This already cases posted by Dr. Sarah Atalla. Case number 2, a 50 years old male patient, 8 months post-transplant, 50 years male, 8 months post-kidney transplant, 2 weeks diffuse papular rash, 4 to 5 days diffuse myalgia, 4 to 5 days loose stool, poor intake, decreased urine output. The patient came by diffuse papular rash, diffuse myalgia, and 4 to 5 days also with diarrhea and decreased oral intake and anorexia and decreased urine output. NADD SCD kidney transplant March 2020, end-stage kidney disease or renal disease secondary to hypertension. Hypertension since 26 years. AKI required temporary IHD in 2010 with partial recovery. Kidney biopsy showed thrombotic microangiopathy, no evidence of microangiopathic microangiopathic hemolytic anemia. Secondary workup, including genetic screening for typical HUS, TTP or TTP also negative. Peritoneal dialysis initiated in 2016, allergic rhinitis and gout. Kidney transplant, March 2020, NADD SCD. NADD with neurological determinant death or donor after neurological death, standard criteria donor, not extended criteria donor. And we discussed this in details already in our transplant session before. What you need to know about kidney transplant, this complete session to cover just a summary around for that's the introduction to transplant. Immediate graft function, uncomplicated surgery already after he received transplant in 2020 with immediate SCD kidney transplant. With immediate graft function, basiliximab induction, standard triple immunosuppression, tacrolimus, MMF, and prednisone. With basiliximab induction, CMV donor positive and the recipient negative, valganciclovir already prophylaxis already ongoing, ABV also donor positive and recipient positive, BGB prophylaxis septra, discharged on post-operative day 5 with creatinine 106, discharged on creatinine 106, post-operative day 5. Post-renal transplant clinic follow-up, regular surgical wound healed well. Ureteric stent removed at 6 weeks. Then just to remind you, any stent removed from 6 to 8 weeks. PD castor removed July 2020. Infection screening and prophylaxis. CMV valganciclovir continued for 6 months. CMV PCR positive September 2 and September 22. BK PCR 2 and 3 and 6 months was negative. BK PCR 2 and 3 on 6 months was negative. Septron held transit in June 2020 for increased ALT, and then held one since October 2020 for leukopenia, also the Septra. Gout flare up July and August 2020 improved with increasing prednisone to 30 milligram for 5 days. Both times, any gout during transplant, we can increase the prednisone. We can give colchicine 0.6 ml daily. We can give also allopurinol 100 after that, and titrate until to cut down the level to below normal. This is some medication, and you can give analgesic, either Tylenol, paracetamol, or hydromorphone. You can give some patient with severe pain. GERD symptoms after stopping pantoprazole, and no post-transplant diabetes. Immunosuppression, prednisone 5 mg, Advagraph dose with stack level 4 to 9, Myvortex 360 BID decreased already because leukopenia, October 2020. Graft function stable, creatinine between 90 to 100 until July 4, 4 months post-transplant. After 4 months from transplant, creatinine increased to 140 to 155 since August, October 2020. Blood pressure controlled, one agent, urine albumin creat ratio 6.7. TAC level, I think within normal. TAC level is in target, microalbuminuria. TAC level in target was in target this, for adherence issue. Peaky PCR negative, urine culture is negative also. Ultrasound, no hydronephrosis, no Doppler. In this, any transplant came to emerge with any symptoms, don't forget to ask for ultrasound, especially with fever or abdominal pain or graft tenderness like that. Planned for graft biopsy at outpatient, got date November 2020, suspicion of rejection. We suspect for rejection for this rising creatinine 140 150 from baseline around 100. We suspect also rejection is the most important and the first differential diagnosis. Low probability of recurrence of yet undiagnosed primary disease, TAC toxicity as out, all this is out. And November 3, called the transplant clinic, missed the biopsy. Patient missed the biopsy and reported progressive weakness, fever, runny nose. The patient already booked as outpatient kidney biopsy, and the patient already missed the biopsy and called the care clinic and reported progressive weakness, fever, runny nose, dry cough, few episodes of diarrhea or intake. November 4, seen in the clinic, diffuse rash and the back and the legs, suspected shingles, herpes zoster. Started valacyclovir 500 BID, creatinine at that time 450, adjusted to creatinine clearance, called in for direct admission to nephrology. This patient at that time admitted to nephrology under kidney transplant team. Any shingles will start with valacyclovir, not Valgan, valacyclovir 500 BID and adjust according to creatinine clearance. Admitted November 6, a subjective fever at November 6 with chills, loose stool still with diarrhea, no nausea, no vomiting, decreased urine output, no dysuria, hematology, generalized myalgia, pain and the back over the graft also, rhinorrhea, nasal congestion, no cough, no short of breath, no hematemesis, no chest discomfort, rash over the back and sigh, healing, no headache, altered level of consciousness or seizure also documented. Her home medication, prednisone 5 mg, Advagraph 8 mg, MMF and hold, Cetera and hold, bisoprolol 10 mg daily, and verasulfate or verasfumulate 300 mg daily, valacyclovir 500 mg per oral BID, started November 4 for shingles query, herpes zoster. Their exam, the patient fully conscious oriented, just lethargic, weak, blood pressure a little bit hypo, saturated well, temperature is okay, GVB flat, chest clear, heart is okay, abdomen diffuse, tender. When you have abdomen diffuse, tender on examination, including graft and suprapubic, don't forget CMV viremia. No peripheral edema, diffuse papular rash, no vesicular rash seen. Over the lower back, buttock and thigh. Sacral wound, already we have sacral wound 5 to 5 centimeter, no discharge, not infected. Preliminary investigation of hemoglobin 108, white blood cells, leukopenia 1.9, platelet is okay, 219. And here neutrophils 0.2, lymphocyte 0.4, monocyte 1.2, eosinophils 0, basophils 0, creatinine 600 plus from and normal baseline assumption around 100, blood urea nitrogen 41. Sodium, potassium, chloride, CO2, just it was a high iron gap, metabolic acid was high iron gap. Calcium 2.4, phosphorus okay, magnesium okay, total bilirubin elevated, and direct bilirubin also elevated. All this should be less than 20. ALT also is elevated, ACT is elevated, and alkaline phosphatase is normal, albumin is 23 is low. We have here also abnormality in hair liver enzymes, CK, LDH is normal, and lactate 3.3, CRP already is high, 300. CRP is elevated also, troponin 17, Tamari, 50 years, male patient, 8 months, post-renal transplant presenting with AKI, creatinine from 100 to 600 plus, severe leukopenia. The patient presented now to you in the clinic in the emergency consult, AKI, severe leukopenia, neutropenia, lymphopenia, monocytosis, diarrhea, and diffuse papular skin rash. Further kidney-related workup, urine analysis, blood positive, plus to blood, leukocyte is negative, nitrate is positive, protein 1 gram, and urine light sodium 24, potassium 33, chloride 17, urine microscopy, few heme granular cast. This was picture of 18. Tacrolimus mass is 3.2, staph level C0, 3.2. Also is a little bit accepted or a little bit low, maybe risk of rejection also. Ultrasound graft or Doppler no hydronephrosis, small peri-transplant collection 2 centimeter, normal Doppler indices also. AKI differential diagnosis for this patient, pre-renal. You should, any patient with AKI, just put in your mind pre-renal, renal, post-renal, pre-renal IV fluid, or for any, we started with IV fluid for volume expansion. We suspect that from this heme granular cast because ETN already diagnosed by urine microscopy. Transplant related maybe either rejection or recurrence of undiagnosed native kidney disease or de novo GN. Also put in your mind recurrence or de novo or rejection or thrombotic microangiopathy or CNI toxicity. You should put in your mind, or infectious. And just don't forget an infection, CMV, PK virus, EBV virus, Epstein-Barr virus. With both these 3 main infectious topics in your mind: CMV viremia, CMV virus nephropathy, and PK nephropathy, and EBV nephropathy also, both in your differential diagnosis. Infection workup, already blood culture November 6, Pseudomonas aeruginosa, and the Enterococcus coliaci. This patient in his blood culture now bacteremia for Pseudomonas and the Enterobacter. Urine culture is negative. CMV PCR around 3 logs already, around 300 international unit per ml. This is positive already for this patient. PCR is negative. Herpes simplex 1, herpes simplex virus 2, varicella zoster for blood. All this PCR is negative for all this virology. Monospot negative for heterophil antibody for infectious mononucleosis, and the COVID is negative also. The patient management started meropenem for this blood culture Pseudomonas and Enterobacter. Started meropenem and valganciclovir, renally doses. Valganciclovir because CMV positive, and I think ID stop valaciclovir we are using only if this varicella zoster virus already is positive but is negative now. So valaciclovir is stopped, rash not suggested for zoster. Continue meropenem until source identified. Diarrhea subside at admission, so stool subside at admission, so stool culture not sent. CT abdomen during this admission, intra-abdominal collection, air in a collecting system of transplanted kidney due to a Foley at urology. Repeat ultrasound after removing the Foley, resolution already done. Left native kidney, hydronephrosis at uretropelvic junction here, hydronephrosis at uretropelvic junction, and the non-obstructive calculi, same compared to previous CT as by urology. Unlike focus X-ray sinus suspected periodontal abscess, CT sinus no drainable collection, but widespread dental caries, no source of current infection as per dentist. No urgent teeth removal. Repeat blood culture negative after 1 week. Switch to ciprofloxacin to complete 14 days for Pseudomonas. Immunosuppression stress dose steroid IV hydrocortisone, prednisone 10 mg. We started by giving stress dosing, resumed prednisone 10 mg, MMF on hold. Due to CMV and leukopenia, advagraph required decrease in dose a week after admission, and this trough level for this patient during admission, FK 506 level, tracrolimus level. All this ranged from admission till now this from November 4 and this November 17. All the target level here and around between 7 and 10. Course in hospital also from November 5 here, creatinine like that. So look for a trend of creatinine after management of infection, and this CMV viremia, creatinine from 600 reach 115. And this picture of leukopenia here during admission on November 5th or 4th, and this now November 18th. This picture of white blood cells and the hemoglobin already, I think, around his baseline from this, and the platelet already is entered thrombocytopenia in this period and now normalized. And this other picture for neutrophils already improving, and the lymphocytes and the monocytes, everything is improving. Hematological workups. Hematology was involved for rapidly decreasing platelet count. You should ask hematology in patients with pancytopenia. Low probability of hits, unlike DIC or drug-induced, so be related to sepsis and CMV. Hematology blame sepsis and CMV, improved already with treatment as we saw before here. Everything is improving with treatment of molybdenum and valganciclovir. And here LDH during the admission, and the last one 300, bilirubin is improving from admission 89 here to 35. Haptoglobulin is high, already not low, not hemolysis. INR is, I think, is around is normal. BTT is okay, fibrinogen is high, not low, and the D-dimer, whatever. Course in hospital, complaint of odynophagia and difficulty swallowing, differential CMV or versus candida esophagitis versus GERD, had pre-transplant history already for the GI consulted, esophageal duodenoscopy, upper endoscopy that showed multiple small healed esophageal ulcer and grade B esophagitis. Biopsy were taken, no esophageal candidiasis. Ulcer atypical for CMV, continue on pantoprazole. Discharge after 2 weeks of admission, AKI resolved, continue on ciprofloxacin for 14 days, continue on valganciclovir 900 mg BID full dose, as estimated due for more than 60 ml per minute with plan to monitor CMV PCR. How common is post-prophylaxis delayed onset CMV, previously known as late onset CMV disease in kidney transplant recipient? What are the indirect effects of CMV infection? Does prophylaxis for CMV prevent other infection in kidney transplant recipient? Infections, all this will come discuss next slides. Infection post-solid organ transplant, either from a donor-derived infection or recipient-derived infection to kidney transplant from donor or from recipient. Here, within the first months, we discussed this before, with infection with antimicrobial resistance species, MRCA, VRE, Candida species in the first months post-transplant, aspiration, urinary castor infection, folic acid, and wound infection and stenosis leak, Clostridium difficile. All this can be suspected in the first months, and this after from 1 month to 6 months. With BK virus nephropathy and BGB already, CMV, hepatitis B, Clostridium difficile, hepatitis C, adenovirus, Cryptococcus, Mycobacterium, and pneumocystis, varicella, CMV, BV, hepatitis B. All this can be suspected. More than 6 months, urinary tract infection may be, Aspergillus may be, and another CMV, BV, hepatitis B, HS, all can be suspected after more than 6 months. Don't forget the structure of our CMV virus. This component of the virus, the glycoprotein 1, the glycoprotein 3, and this is the coat envelope of the virus, and this is the capsid containing this genomes for the virus, and this is the genome already, the capsid and the genome, and the collagen here around the virus. CMV virus is a major cause of infection-related morbidity and mortality in kidney transplant. The most significant risk factor for developing CMV infection after transplant depends upon the donor and the recipient CMV serostatus. If the donor positive and the recipient negative, this is the most important risk factor. The most common viral infection in solid transplant, most common opportunistic infection in kidney transplant, 8%, major impact on the graft survival, morbidity, and mortality. Risk factor for CMV virus, donor recipient mismatch, if donor positive and recipient negative, is more than the other. Use lymphocyte depleting agent like LTG or thymoglobulin. Older donor more than 60 years, all this risk factor, allograft rejection, and receiving AV immunosuppression. This will activate the CMV infection, concurrent infection from other viruses. Interleukin-2 receptors does not increase the risk. Donor negative, recipient negative, incidence of CMV less than 5%. If donor negative and the recipient negative. Interleukin-2 receptors blockade like basiliximab or Simulect, not increase risk. Donor negative, recipient negative, incidence of CMV disease less than 5%. Ultrasound kidney transplant, CMV status of donor recipient pairs. Donor positive, recipient negative 18%, donor positive, recipient positive, or donor negative, recipient positive 61%, donor negative, recipient positive, risk of CMV 21%. What is the difference between CMV infection and CMV disease? CMV infection, evidence of CMV replication regardless of symptoms. CMV DNA viremia by NAT nucleic acid testing, CMV antigenemia antigen testing, or CMV viremia viral culture. Primary infection, donor-derived. Reinfection, donor-derived, or reactivation. Reactivation leading recipient infection. Donor-derived infection are the most common. CMV infection, evidence of CMV replication regardless of symptoms. By CMV DNA viremia by nucleic acid testing, notice his name summary is NAT, CMV antigenemia antigen testing, or CMV viremia viral culture. Primary infection from donor-derived, reinfection, donor-derived, or reactivation of latent recipient infection. Donor-derived infection are the most common. CMV disease pose evidence of infection as well as symptoms. CMV symptoms like fever, malaise, arthralgia, leukopenia, thrombocytopenia. Tissue invasive disease, enteritis, colitis, hepatitis, nephritis, pneumonitis, meningitis, encephalitis, retinitis, with demonstration of CMV in tissue specimen by histopathology. The most important, the symptoms will come to any patient post-kidney transplant: fever, malaise, arthralgia, leukopenia, thrombocytopenia, and the tissue-invasive disease like enteritis. Patient will come by gastroenteritis, colitis, hepatitis, elevated liver enzyme, nephritis, pneumonitis, also meningitis, also encephalitis, and retinitis, with demonstration of CMV in tissue specimen by histopathology. CMV viral syndrome, more than one signs from the above with active infection like fever, malaise, leukopenia, atypical lymphocytes, and thrombocytopenia, and the transaminitis by 2. And this picture for internuclear eosinophilic infiltrate. This already illustrated eosinophilic intranuclear inclusion of hyaline materials like oval eyes, characteristic, okay? This by histopathology diagnosis is intranuclear eosinophilic infiltrate, like oval eyes, with our topic first slide. Indirect effect of CMV, decrease the patient survival, decrease the graft survival. This is a complication of CMV. Decrease in patient survival, decrease in graft survival, increase immunosuppression, coexistence of opportunistic infection, and biopsy-proven acute rejection also. Biopsy-proven acute rejection in the first 12 months. PTLD is a risk, also risk factor for CMV risk factor for post-transplant lymphoproliferative disease, and and post-transplant diabetes, and the transplant TMA, thrombotic microangiopathy also. CMV diagnosis and monitoring, quantitative by DNA PCR. That we'll see now a reference for that. If less than 2,000, that's okay, or 2 logs. Of more than 2,000, you should treat, and we'll come to that now. Universal prophylaxis versus preemptive therapy. Universal prophylaxis administration antiviral medication to all patients with at risk of, especially at risk patients, 3 to 6 months. Preemptive therapy lab monitoring performed at regular interval to detect early viral replication. By follow-up this patient, you should treat. If the CMV load start to be above 2,000, you should start management for your patient. And with universal prophylaxis versus limited and this prophylaxis and the preemptive, early CMV viremia prophylaxis is real, and you can read this. We'll not lose time for that. And CMV prophylaxis duration, and we'll come to the most clinical point here. If it's donor positive and recipient negative, we'll give 6 months recommended. Recipient just positive, 3 months. If recipient positive, 3 months, whatever the donor. If the donor only positive and recipient negative, 6 months, 3 months here. Negative, routine prophylaxis is not recommended. Some said you can give acyclovir. Or use liquid bleeded or CMV seronegative blood product recommended for decrease the risk of transmission of CMV virus with the blood. Rule of screening or prophylaxis for CMV when transfused uncertain. CMV prophylaxis duration and the impact study as a donor positive, 318 kidney transplant recipient, CMV disease already developed by this significantly already 36.8% in 100 days versus 1,600. 36 patient not received prophylaxis in comparison by 16, significantly important. I will not go to more details. No difference in the biopsy-proven antibody-mediated rejection or graft loss with the prophylaxis or not, but only this regard the 1 year survival for the patient and the graft. The patient is 36.8% from 16 of CMV disease will develop this incidence of CMV disease. The patient received prophylaxis and this not received prophylaxis. I think the CMV decreased from within 1 day with the prophylaxis in comparison by 200 days. Better if you will prolong days or course of CMV prophylaxis will give you significant decrease in CMV disease as regard the impact study. As I mentioned here, that on 100 days and 200 days, 200 days will give you a better improvement or decrease in CMV disease already in comparison by 100 days prophylaxis. Post-prophylaxis delayed onset CMV disease occurring after discontinuation of prophylaxis. This name delayed onset CMV disease after discontinuation of the valganciclovir, for example, previously called late onset CMV disease, found in all studies evaluating universal prophylaxis 18 to 30% at 12 months, usually 3 to 6 months after completion of antiviral prophylaxis. And what is the risk factor for that, especially if donor positive lacked development of significant CMV specific T-cell mediated immunity, short course of prophylaxis, higher level of immunosuppression, and graft rejection, all these risk factor, either donor positive, lack cell-mediated immunity, and short course of prophylaxis, high level of immunosuppression, and graft rejection. Post-prophylaxis delayed onset CMV disease associated higher rates of mortality and graft loss. All this CMV monitoring by CMV PCR, no need to mention details for that. CMV prophylaxis, antiviral prophylaxis with valganciclovir or intravenous ganciclovir should be given to patient receiving lymphocytes, especially patient with ATG, lymphocyte bleeding antibodies, for the treatment of rejection, usually 1-3 months. Similar strategy may be considered during treatment of rejection with high dose steroid, weak, very low evidence. And CMV prophylaxis, which antiviral, according to creatinine clearance, valganciclovir has equivalent efficacy to oral ganciclovir. valganciclovir had equivalent efficacy to oral ganciclovir in donor-positive recipient negative transplant. Acyclovir determined to be inferior to ganciclovir for the prevention of CMV, while acyclovir is inferior to valgan oral ganciclovir for the. And then the creatinine clearance, we can give it dose according to creatinine clearance here. CMV prophylaxis valacyclovir versus valganciclovir. High dose valacyclovir prophylaxis effective for CMV disease and CMV viremia prevention in both donor-positive recipient negative, donor-positive recipient positive kidney transplant recipient. Advantage of high-dose valacyclovir: low bone turnover, suppression, low cost. Disadvantage: high bills burden, neuropsychiatric side effect, especially with low GFR. And fifth, how you can give according to creatinine, this is valacyclovir. CMV disease treatment in non-severe CMV disease, non-severe CMV disease, just valganciclovir or intravenous ganciclovir. Did Adrian Victor trial equal efficacy already between both IV or ganciclovir or valganciclovir, equivalent plasma concentration. Life-threatening CMV disease, IV ganciclovir is recommended. If life-threatening CMV disease, will give IV ganciclovir or oral ganciclovir, acyclovir, or valacyclovir should not be used for CMV disease. I will miss this also. The according to creatinine clearance, how to calculate those. CMV disease treatment duration of treatment determined by weeks, monitoring of viral loads, continue treatment until 1 or 2 consecutive negative sample. This hour, when you start the treatment, you should decide when you will stop. Continue treatment until 1 or 2 negative sample for CMV PCR. Blood. Minimum treatment, of course, at least 2 weeks, minimize the risk of development of resistance, minimize disease recurrence. CMV recurrence risk factor for recurrence: primary CMV infection, patient not immune before, not infected before. This is donor kidney transplant, high initial viral load, slow reduction in viral load on treatment, multi-organ disease, treatment of rejection during CMV disease, persistence viremia, when transferred to secondary prophylaxis. All this risk factor for recurrence, especially deceased donor, primary CMV infection, high initial viral load, slow reduction in viral load on treatment, multi-organ disease, treatment of rejection with heavy immunosuppression, persistent viremia when transferred to secondary prophylaxis. Secondary prophylaxis, prolonged therapy with standard prophylaxis does after successful treatment course duration, usually 1 to 3 months. Refractory and resistant CMV, refractory definition. Refractory CMV infection already with CMV DNA viremia or antigenemia increase after at least 2 weeks of appropriate dose of antiviral treatment or therapy. This refractory CMV infection. Refractory CMV disease, worsening signs, symptoms, and the progressive end-organ disease after at least 2 weeks of appropriate dose of antiviral therapy. Resistant CMV, presence of viral genetic alteration that convert reduce susceptibility to 1 or more antiviral drugs. If, as regards definition, antiviral drug resistance, ganciclovir, valganciclovir resistance occurs mainly in the donor positive and recipient negative kidney transplant recipient. The incidence of true ganciclovir resistant CMV infection after solid organ transplant is 0 to 3%. Increase in viral load in the first 2 weeks of treatment are not predictor of drug resistance. These drugs you should ask for UL97 mutation do not affect the vascularity or severe susceptibility. UL54 polymerase also drug resistance mutation may confer cross resistance for other drugs. You should ask for this genetic mutation UL97 UL54. And this will not do headache for you. Antiviral drug resistance, we'll see this in the end. Increase here, increase or change in viral load. This is the drug resistance, just in summary. We'll assess this genetic mutation, UL 54, UL 97, resistant testing. Fifth, severity of CMV infection, non-severe CMV empirical therapy, non-severe CMV disease, will give empirical therapy. Increase intravenous ganciclovir up to 10 milligram per kg 12 hours, switch to foscarnet, full dose. If severe CMV disease, empirical therapy, switch to foscarnet with high dose or full dose. And definitive antiviral therapy is based on genotype resistant testing and clinical response. Just unproven investigation may be required. With according to resistance, just will treat according to genetic mutation, either UL 54 or 97. Treatment option for resistant CMV. If you have one patient with resistance, high dose ganciclovir or valganciclovir, foscarnet, cidovivir. All this, the dose here for foscarnet 60 milligram IV, you can read later, and cidovivir 5 milligram per kg. Once weekly for 2, then every 2 weeks thereafter. This is the dose of cidovivir and the foscarnet 60 milligram per kg every 8 hours. Or 90 milligram per kg every 12 hours. This is the foscarnet, and this is the side effect of all. Either the treatment option will start by valganciclovir, IV ganciclovir, valacyclovir, not recommended already. This is the most important medication is valgan and IV ganciclovir, and then foscarnet cidovivir. And we have new medication. We'll discuss this in details later. And this in patients with resistance will start by foscarnet and the cidovivir. And this comparison already between valganciclovir and the ganciclovir, foscarnet, cidovivir, and vomiviricin. And this just a comparison, induction, maintenance, and the principal adverse effect and disadvantage for each one. You can read. Another antiviral option, like CMV, specific hyperimmune globulin or standard IVIG can be given. Consider if hypo, gamma, globulinemia. You can ask for immunoglobulins, like immunoglobulin A, M, G, D, or you can ask if the patient is low in the blood, you can give him IVIG to that to increase the antibodies to this virus. Other agent, anti-CMV effect, in vitro, mimotors, leflunomide, artesunate, I think you can use leflunomide, but leflunomide common with the BK virus also. A newer agent like Maribavir, phase 3 clinical ongoing for treatment of resistance or refractory CMV. Already this is now approved by FDA. This is Maribavir. And the letermovir, a novel viral transaminase inhibitor, recently approved for CMV prophylaxis after allogeneic hematopoietic stem transplant, not approved for use in solid organ transplant recipient, and randomized control trials comparing letermovir and valganciclovir for prevention of CMV in donor positive and recipient negative kidney transplant ongoing. And this I will not do headache for you for that. And this valganciclovir oral solution and the prophylaxis by dose according and valganciclovir prophylaxis dose and the treatment dose according to estimated GFR. You can take a picture for that. With normal GFR, will give 900 daily, whatever, in prophylaxis or treatment 900 twice daily, and between 40 to 60, 450 daily, 400 twice daily. The treatment will double the dose, but in prophylaxis will give half dose. CMV is the most important transplant-related infection, affecting around 8% of renal transplant. A recipient, despite the routine use of prophylaxis antiviral therapy, in table 16.5 from Oxford, CMV is present in abundant in the body fluids, saliva, urine, breast milk, genital secretion. This is the source of CMV, not like Epstein-Barr virus before: saliva, urine, breast milk, genital secretion. of infected individuals and is usually transmitted by close contact. This is a CMV, close contact, it's contact isolation. Primary infection commonly occurs in childhood or adolescence and is either asymptomatic or cause non-specific upper respiratory symptoms, illness, or infectious mononucleosis type illness. There are many strains for CMV and reinfection is common. Following primary infection, the virus remains latent in lymphocyte reactivation, unusual except in the event of immunosuppression. Latent infection is defined by CMV IgG, seropositive. In UK, about 40% 20 years old and 80% 60 years old are CMV seropositive. Risk factor for CMV disease without antiviral prophylaxis: if a donor positive, recipient negative, around 50 to 80%, both positive 10 to 30%, donor negative, recipient positive 0 to 30%, donor negative, recipient negative 0%. This is the risk factor for CMV disease without antiviral prophylaxis: 80% if donor positive and the recipient negative, 0% if both negative. CMV and the transplant recipient develop CMV disease in several ways: transmission of virus the donor from donor organ, or primary infection of CMV non-immune recipient, super infection with different CMV strains, seropositive reactivation of latent infection. And just one moment, please, because I need to connect it to charge. One moment. CMV and sorry for that, because connected to the chart. CMV and transplant recipient transmission of the virus with donor organs, primary infection of CMV, non-immune CMV, patient who is not immune before, not infected before, this is a risk factor also, and super infection with different CMV strains of CMV seropositive, or reactivation of latent infection. This CMV disease in several ways develop in our recipient, either from primary infection or super infection or reactivation of latent infection. Direct effect, symptomatic CMV viremia seroconversion. Asymptomatic CMV viremia seroconversion and immunity. Symptomatic CMV disease typically occurs between 1 to 6 months post-transplant in absence of antiviral prophylaxis. Most common manifestation of symptomatic CMV viremia, tissue-invasive disease, CMV infection if the transplanted kidney involved. Indirect effect, immunosuppression can also activate CMV disease. CMV infection suppress both T and B cells mediated immunity, superimposed opportunistic infection by immunosuppression. Acute rejection despite enhancing immunosuppression. CMV also increases HLO class 1, class 2 expression within the organ transplant, especially with acute rejection, and increase also acute rejection. Long-term effects, CMV infection has been associated with developmental allograft vasculopathy and nuanced diabetes after transplant, also related to CMV infection. Clinical manifestation of CMV, clinical manifestation of CMV disease, symptomatic CMV viremia like fever, night sweat, weight loss, anorexia, malaise, myalgia, arthralgia. Lymphopenia and thrombocytopenia also involved, subclinical hepatitis, tissue-invasive disease, ulceration affecting any part of the GI, esophagus, dysphagia or dysphagia like our patient. gastritis, nausea, vomiting, dyspepsia, duodenitis, enteritis, colitis, abdominal pain. This is the most common complication or clinical picture of CMV is GIT and perforation. Also, GIT bleeding sometimes torrential is common. Pneumonitis also, some patient came by fever, cough, and short of breath, hypoxia exacerbated by exercise. When patient coughing, hypoxia like BGB pneumonia. Chest X-ray, just maybe infiltration or localized diffuse nodular infiltrate also, and just BGB and CMV both in differential diagnosis also. Chorioretinitis also, and the graft dysfunction, CMV infection lead to graft decrease in GFR, and also will come by acute kidney injury or graft dysfunction. There are two tests that provide rapid and accurate diagnosis of CMV, just either by detection by CMV DNA by PCR. This is the most common test: CMV DNA PCR and the histopathology. What is the diagnostic test for CMV? Either CMV DNA PCR or histopathology. We can diagnose by this inclusion, eosinophilic inclusion, like all eyes in our histopathology already. Other tests I can within the pancytopenia and the transaminitis, elevated liver enzymes, also chest X-ray endoscopy for chorioretinitis. Management, as I mentioned for you, antiviral therapy, PO, valganciclovir or IV ganciclovir is the mainstay of treatment. Treat for at least 2 weeks or until CMV by PCR is negative. Tissue-invasive disease may require 4 to 6 weeks therapy. Monitor closely for relapse around 20%. Consider decrease also immunosuppression, either stop or reduce ASA or MMF or mycophenolic acid, or decrease CNI by 50%, but look out for acute rejection rejection. Do decrease and keep the patient to be rejected at the end. Decrease the antimetabolite, also decrease the risk of ganciclovir-induced myelosuppression. CMV hyper IVIG also for a patient with hypogammaglobulinemia, pseudovivir, and foscarnet are a toxic alternative to ganciclovir used if ganciclovir intolerance, usually myelosuppression or resistance uncommon. Then antiviral therapy for herpes virus and disease dose. And did ganciclovir already dose 5 mg per kg and will VID or OD according to creatine GFR or creatinine clearance. CMV prophylaxis, the risk of developing CMV disease predictable based on the donor and the recipient CMV matching. Universal prophylaxis, as we mentioned, all donor positive, recipient positive should receive for at least 6 months. If a donor positive, recipient positive, you should give 3 months, especially with ATG induction. Valganciclovir is widely used for CMV prophylaxis. Begin treatment with 10 days of transplantation. Those based on strategy for most given for 100 days with 10 to 20% patient developing CMV disease after prophylaxis discontinue. 200 days treatment may decrease subsequent CMV disease, as we mentioned before. Valganciclovir prophylaxis is cheaper valacyclovir. Valacyclovir is cheaper than valganciclovir, but effective when given and the prophylaxis for 90 to 100 days. Those also dependent on renal function, and if estimated GFR more than 60, you can give 2 grams daily. Very inconvenient to take. High dose acyclovir or intermittent IV ganciclovir for or CMV hyperimmunoglobulin are either less effective or inconvenient to administer. Preemptive antiviral prophylaxis. In this approach, all high-risk patients have CMV PCR performed weekly for the first 4 to 6 weeks of post-transplant, 4 to 6 months post-transplant, and then monthly up to 1 year. In high-risk patient, CMV performed weekly in the first 4 to 6 months post-transplant, and then monthly after 1 year, up to 1 year. Valganciclovir prophylaxis started if CMV viremia increase a predefined threshold for around 2 logs or 2,000. This approach prevents unnecessary valganciclovir treatment at the expense of many CMV PCR testing. Home message: what is the CMV high-risk patient? This patient with recipient negative and donor positive should receive valganciclovir for 6 months prophylaxis. This is my home message for you: 6 months prophylaxis, especially this patient with high UZTG induction also. What is the CMV moderate risk? Recipient positive, IgG, pre-transplant, or recipient negative and donor negative with ATG induction. Valganciclovir we need to give 3 months. What is the CMV low risk? This is recipient negative, donor negative, no ATG induction. We can give or no. We can't give prophylaxis. Maybe we will not give prophylaxis, and some books mention we can give acyclovir 400 milligram per oral BID for herpes simplex virus. Preemptive donor positive, recipient positive, or donor negative, recipient positive. Acyclovir also 400 milligram BID for herpes simplex, and check CMV PCR every 2 weeks until 24 weeks. How often do you check CMV PCR after stopping prophylaxis? Maybe after 1 month, 3 months, 6 months after stopping prophylaxis. 136, 136. What is the CMV disease? Viremia plus symptoms of tissue invasive colitis, enteritis, as we mentioned before. Viremia plus symptoms of invasive disease, especially GIT, colitis, enteritis, transaminitis also. How do you treat severe CMV disease? Either by ganciclovir 5 milligram. Any severe CMV disease, ganciclovir 5 milligram IV every 12 hours. No adjustment after first 48 hours of starting treatment. Consider holding MMF for 3 days or 1 week or 2 weeks. What CMV syndrome? As we mentioned, syndrome viremia plus CMV disease, the previous one. This CMV syndrome viremia plus fever, malaise, and leukopenia, thrombocytopenia. This is the CMV syndrome. CMV viral syndrome, as we mentioned before, more than one signs with active infection, fever, malaise, leukopenia, typical lymphocytes, thrombocytopenia, transaminitis. Invasive CMV disease, specific target organs, symptomatic plus histopathology. Replication on the peripheral blood may be absent. Quantitative CMV assay of invasive gastritis, colitis, chorioretinitis. CMV syndromes, fever, malaise, fatigue, myalgia, leukopenia, and thrombocytopenia. CMV tissue invasive disease, hepatitis, pneumonitis, colitis, pancreatitis, carditis, encephalitis, retinitis, nephritis. Just don't forget colitis, enteritis, hepatitis, pneumonitis is the most common we saw. CMV risk factors like donor positive, recipient negative, older age, HLA mismatch, especially donor positive, recipient negative, ATG more than the basilic induction therapy. How do you treat CMV? Viremia, 1,000 to 2,000 log viral load, and asymptomatic reach just follow-up, routine follow-up. CMV every week for 3 weeks, and no change in immunosuppression. Or you can cut down if increasing. Viral load increased more than 2,000, start by valganciclovir and recheck CMV every week for 3 weeks. If you viral load more than 2,000 or 2 logs, more than that, start the valganciclovir and recheck CMV PCR every week for 3 weeks. Monitor after treatment CMV PCR every week for 4 weeks, then every 2 weeks for 1 month, then every 2 to 3 months. Adjustment valganciclovir or ganciclovir to according to creatinine clearance. Don't forget that. When you will treat and when you will follow up to 2,000, just follow up. More than 2,000 or 2 logs, start valganciclovir and follow up every week, and then 2 weeks, every month, like that. How to adjust the Valgan or ganciclovir according to creatinine clearance? This ganciclovir 5 milligram per IV every 12 hours, and this according to creatinine clearance dose, and this valganciclovir 900 every 12 hours, and this adjusted dose already. When do you prefer IV ganciclovir over per oral? Valganciclovir, especially patients with severe CMV invasive disease or extremely high viral load. Okay, when you will use IV ganciclovir in comparison by per oral valganciclovir if severe CMV invasive disease or extremely high viral load. How do you define resistant CMV if CMV continue to rise more than 1 log for can increase from the baseline after 2 weeks of after 2 weeks resistance. After 2 weeks, continue rising or persistence systemic illness after 2 weeks from therapy with the or significant rise in the CMV PCR after 1 week of adequate treatment, but should be 2 weeks. Send resistance panel. What is the resistance panel? UL 54 UL 97 UL 54 genetic testing for resistance of CMV. Severe treatment option: high dose IV ganciclovir, foscarnet IV, litermovir 480 mg daily, reduce CNI and motor by 50% when litermovir started. Litermovir started, just decrease the CNI by 50 or motors by 50%. This is a treatment option for severe CMV disease. High dose IV ganciclovir, foscarnet IV, litermovir 480 mg daily, and reduce CNI and limiters by 50% when litermovir started. What is the secondary prophylaxis? Prophylaxis after treatment of severe infection. Ganciclovir we can give 1 month as a secondary prophylaxis. Then you check CMV PCR IgG for seroconversion. Follow CMV PCR at 1 month, 3 months after completion. If no secondary prophylaxis after treatment, check CMV PCR every weeks for 4 weeks, then every month for 3 months. If no secondary prophylaxis after treatment, check CMV PCR weekly for 4 weeks, then monthly for 3 months. If you will not start CMV prophylaxis. CMV as a post-transplant infection, genetic sequence, detect mutations that cause drug resistance, like UL 97 mutation and 54 54 mutation, 97 and 54 mutation. All this resistance, and the most frequent resistance to ganciclovir resistance is UL 97 mutation. UL 54 mutation, ganciclovir, foscarnet, silobivir resistance to all already. UL 54 mutation. Remember, this checking after any event of prolonged immunosuppression reduction. Don't forget rejection. When you will decrease the immunosuppression, just the donor-specific antibodies should be checked to rule out rejection. And this suggests cytomegalovirus CMV prophylaxis protocols. If both negative, just acyclovir you can give. CMV, and you can read also CMV negative recipient, of positive donor will give for 6 months 900 maybe BID or daily according to GFR. Positive recipient, negative donor we can give for 3 months, especially if the patient will receive ATG. If it both positive, we can give for 3 months is here, especially if the patient also receive ATG. New FDA approved medicine, his name Live-Tinicity, and the trade name already active ingredient Maribavir. This is a trade name, Live-Tinicity, and the active ingredient Maribavir. This Live-Tinicity, I think this is the trade name, and this active ingredient Maribavir. To treatment post-transplant CMV infection or disease that not respond to other antiviral treatment options. This is, I think, new era in management of CMV resistance to antiviral medication. This Live-Tinicity or Maribavir. Mechanism is cytomegalovirus BUL97 kinase inhibitor will inhibit this UL 97 mutation, and this Maribavir for refractory cytomegalovirus infection with or without resistance, post-transplant results from phase 3 randomized clinical trials. You can read this article for this Maribavir if you have any patient with resistance to regular antiviral treatment for CMV viremia. ونتمنى إن شاء الله تكونوا استفدتم، ونسألكم الدعاء بالتوفيق والسداد والبركة في الوقت والمال الأهل والأولاد. ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. وأترككم في رعاية الله وحفظه. والسلام عليكم ورحمة الله وبركاته.